Hello, my name is Christos Iosifidis and I'm going to talk about ophthalmology in this presentation. The topics we're going to cover today include anatomy of the eye, conditions that result in a red eye, that result in visual loss, and systemic diseases that affect the eye, as well the most important ophthalmic emergencies, and a few things about pediatrics in ophthalmology. So to start off, we're going to talk about the anatomy of the eye. The orbit is made up of 7 bones: the frontal, sphenoid, zygomatic, maxilla, palatine, ethmoid, and lacrimal bones. The optic canal is found posteriorly, and it is where the optic nerve passes through and along the optic chiasm and optic tract to reach the lateral geniculate body. Superior orbital fissure is the anatomical structure through which cranial nerves 3, 4, 6, and V1 pass. Inferior orbital fissure is the anatomical structure through which the inferior division of the ophthalmic vein pass. Increased pressure in the orbit can compress and damage the optic nerve. Sinusitis or inflammation of the ethmoid sinus can spread into the orbit and cause orbital cellulitis, which is an ophthalmic emergency. And this is something we're going to talk about in the emergencies section. And finally, blowout fracture can occur due to blunt trauma, most commonly inferior wall. The signs include enophthalmos, downward gaze, and restricted upward gaze, as well as reduced sensation due to compression of the infraorbital nerve. Surrounding the eye are the eyelids or tarsal plates. The conjunctiva covers the white part of the eye, which is the sclera. It combines with the eyelids to form the fornices. Foreign bodies can get caught in these areas and scratch the cornea. The orbicularis oculi muscle is innervated by the facial nerve. When contracted, it can forcefully close the eyelid. Defect of the facial nerve due to Bell's palsy or stroke can cause persistent open eye and thus result in the patient complaining of dry eye. The levator palpebrae superioris muscle in the upper eyelid is innervated by the oculomotor nerve or cranial nerve 3. It keeps the eye open. Oculomotor nerve palsy can cause complete ptosis. And another muscle called Mueller's muscle behind the levator is innervated by the sympathetic nervous system. This muscle also functions to keep the eye open. Defect of this muscle due to Horner's syndrome can cause partial ptosis, and this is in comparison to the levator muscle's complete ptosis. The eyelids contain glands called the meibomian oil glands. They secrete the lipid component of the tear film. When these glands are blocked, the condition is called chalazion or stye. The patient may present with painful, swollen lump of the eyelid, and the management is with hot compression and massage. Although the prognosis is good, this can be recurrent, and persistent blockage of the gland may require incision and curettage to prevent formation of abscess. Other differentials for eyelid lumps include basal cell carcinoma, squamous cell carcinoma, and melanoma. Another condition of the eyelids is blepharitis, which is a chronic inflamed eyelid. Debris can be seen on the eyelashes, along with a red conjunctiva, and the eyelid will be extremely itchy. This condition is associated with 3 dermatological conditions: seborrheic dermatitis, atopic eczema, and acne rosacea. Treatment is with the use of a cotton bud wetted with bicarbonate solution or diluted baby shampoo to clean this debris. Now onto the anatomy of the globe of the eye. This is the eye is made up of 3 main layers. A tough outer coat, which is transparent anteriorly to allow light to enter, which is the cornea, and opaque posteriorly, which is the sclera. Uvea forms the second and most vascular layer. It is made up by the choroid posteriorly and the ciliary body and iris anteriorly. Finally, the innermost layer is called the retina. The central part of the retina is called the macula, and the center of the macula is called the fovea. The fovea is the area where we form our central vision, which is clear and colored. The cornea does 70% of the focusing of the eyes, and this is where defects in refraction cause short or long-sightedness, i.e. myopia or hypermetropia. The lens does the other 30% of the focusing. The second part of the uvea, the ciliary body, is a smooth muscle which is connected to the lens via the suspensory ligaments. Its function is to allow the eye to focus for near objects. It does this by contracting and changing the shape of the lens to a more curved one. When the eye needs to focus for distance, the ciliary muscle relaxes. This increases the tension in the suspensory ligaments and thus the lens flattens. This is called accommodation. Loss of accommodation can occur with age as the lens becomes harder. This is called presbyopia, and this is why everyone will require reading glasses after the age of 50. The eye is further divided into anterior and posterior segments, with the lens acting as the division line. The posterior segment behind the lens is filled with the vitreous humor. The anterior segment in front of the lens is filled with the aqueous humor. The anterior segment is then further divided into anterior and posterior chambers. The anterior chamber is made up by the cornea anteriorly and the iris and central lens posteriorly. The posterior chamber is made up by the iris, lens, and the ciliary body. The ciliary epithelium secretes aqueous humor and maintains the ocular pressure. The aqueous humor is drained at the iridocorneal angle. This angle is lined by the trabecular meshwork, through which aqueous drains into Schlemm's canal and hence into the venous system via the episcleral veins. The ophthalmic artery, which supplies the retina, comes off the internal carotid artery. It gives three branches: the retinal artery, ciliary arteries, and muscular arteries. The optic nerve and inner retina are supplied by the retinal artery. The outer retina and fovea are not perfused from the retinal circulation. Instead, they are supplied indirectly by diffusion of oxygen and metabolites from the choroid. The optic disc is composed of the outer colored neuroretinal rim and the inner pale cap. The disc transmits light from the retina to the brain. The cap has no neuroretinal fibers. You can think of it as an empty space. The ratio of cap to disc should be less than 0.4 when measured along the vertical axis. Glaucoma is an important disease associated with the optic nerve. In glaucoma, the cap gets bigger as the neuroretinal rim gets damaged. Thus, the cap-to-disc ratio becomes bigger. Swelling of optic disc can indicate important diseases. These include raised intracranial pressure due to either space-occupying lesions or idiopathic intracranial hypertension, or it may indicate malignant hypertension, optic neuritis, central retinal vein occlusion, and anterior ischemic optic neuropathy. We are going to cover these diseases later on. And that is all about ophthalmic anatomy. I am now going to talk about some common conditions causing red eye. These are conjunctivitis, episcleritis, scleritis, and uveitis. Other causes of red eye are mentioned elsewhere in this presentation. For conditions not mentioned in the presentation, you only need to know that they exist, and you can look them up on the internet for some pictures. So, conjunctivitis is the commonest red eye diagnosis, and it is divided in three main subtypes: bacterial, viral, and allergic. Bacterial conjunctivitis has mucopurulent discharge, and the causative organisms are Staphylococcus or Pneumococcus. Treatment is with chloramphenicol drops. Viral conjunctivitis is distinguished from bacterial conjunctivitis by its watery discharge, preauricular lymphadenopathy, and a recent upper respiratory tract infection. Organism responsible for viral conjunctivitis is adenovirus, and the treatment is with just lubricants. Both bacterial and viral conjunctivitis should be referred to ophthalmology if they happen to a neonate, if there is no improvement with treatment, or if there is visual loss. Allergic conjunctivitis is seasonal and is related to atopy. It is characteristically itchy. Papilla of the upper eyelid may merge to form large cobblestone-like papilla. Treatment is with sodium chromoglycate. Episcleritis and scleritis are inflammations of the sclera and the most superficial layer of the sclera, which is the episclera. Episcleritis is when only a small region of the superficial layer of the sclera is inflamed. It causes mild discomfort. It is self-limiting and the vision is not affected. It is an autoimmune condition. It is caused by autoimmune conditions, and the management is with lubricants. The use of topical steroids should be considered only for more severe cases. Scleritis affects a bigger region, and there will be severe pain, headache, and pain when moving on eye movement. Vision can be affected. It is associated with systemic diseases such as rheumatoid arthritis and lupus. Management is with topical steroids and non-steroidal anti-inflammatories. One of the use of oral steroids again can be considered in more severe cases. To differentiate between episcleritis and scleritis, phenylephrine drops can be used. What they do is that they blanch the episcleral vessels, and in contrast, deeper scleral vessels are not blanched. Therefore, when used in episcleritis, the vessels will disappear, and when used in scleritis, the vessels will not disappear. Uveitis is the inflammation of the iris, ciliary body, or the choroid. It may also affect the retina. Iris is the most commonly affected, and this is called anterior uveitis. Patients will have a red eye, ocular pain, blurred vision, and photophobia. The most common causes of uveitis are intraocular infection, seronegative spondyloarthropathies such as inflammatory bowel disease and ankylosing spondylitis, or sarcoidosis. Uveitis should always be referred to ophthalmology. The management depends on the cause. If it is idiopathic, then steroid drops or oral steroids can be used. However, if it is infective, then antibiotics should be used. Cyclopentolate drops can also be used. The reason for that is that they dilate the pupil and thus prevent adhesion of the lens to the iris. This is an important complication or sign of uveitis, and it's called posterior synechia. This is adhesion between the lens and iris. The rounded shape of the pupil is lost, and cyclopentolate drops can prevent this from happening. Keratic precipitates may form on the corneal endothelium, and white cells may collect in the inferior anterior chamber. And this is also called hypopyon. Both signs can be seen through the slit lamp. And this is the end of the red eye section. In the next few slides, I am going to talk about causes of visual loss. These include central retinal artery occlusion, central retinal vein occlusion, and the more common age-related macular degeneration, cataract, and glaucoma. Red eye conditions can also cause visual loss. Stroke and optic neuritis can be revised as part of neurology, and thus they have not been mentioned in this presentation, although they are important causes of visual loss. Central retinal artery occlusion is commonly due to an embolic event. The patient will present with acute, painless loss of all the vision, and these are important symptoms to ask during history. The embolus may only affect a branch of the retinal artery, and this will cause only part of the vision to be lost. The loss of vision is unfortunately irreversible. However, some patients may get their vision back after a few minutes if the embolus moves more distally, and this is called amaurosis fugax. And it can happen in a transient ischemic attack, for example. On examination, the relative afferent pupil defect will be present due to extensive retinal damage. The edematous retina will be seen under the fundoscope as swollen and white. The fovea will appear as a cherry red spot on fundoscopy. Acutely, the most important step after identifying central retinal artery occlusion is to investigate for and rule out giant cell arteritis by measuring the ESR. Giant cell arteritis is an important differential of acute visual loss, and it is an emergency which should never be missed. We will talk about it in the emergency section. Acute treatment is aimed at trying to dilate the retinal artery to allow the embolus to pass more distally. Acetazolamide should be used to lower the eye pressure, and ocular massage can also be tried. The central retinal artery occlusion may indicate systemic vascular disease. Therefore, further assessment should include examining and investigating for hypertension, ischemic heart disease, and peripheral artery disease. It is possible that the embolus was passed from the carotid artery. Therefore, Doppler ultrasound of the carotid artery may identify carotid artery stenosis, for which carotid endarterectomy can prevent the possibility of a cerebral embolus. In contrast to central retinal artery occlusion, the causes, examination findings, and management are different for central retinal vein occlusion. Hyperviscosity, hypercoagulable state, inflammation of the veins, or increased eye pressure are all possible causes for CRVO. The patient will present with acute, painless loss of all the vision. Only a branch of the retinal vein may be affected, and this will cause only part of the vision to be lost, similar to the branch retinal artery be affected in retinal artery occlusion. On examination, the relative afferent pupillary defect will be present due to retinal damage. Fundoscopy will reveal retinal hemorrhages in all 4 quadrants, and this will give the appearance of a stormy sunset. There will also be dilated and tortuous vessels, cotton wool spots, swelling of the optic disc and macula, and also possible neovascularization. The central retinal vein occlusion may be associated with vascular disease. Therefore, further assessment should include examining and investigating for hypertension and ischemic heart disease. Hyperviscosity and hypercoagulability should also be investigated for. Macular edema and neovascularization, if present, should be treated with pan-retinal photocoagulation and anti-VEGF injections. Moving on, I am now going to talk about age-related macular degeneration. This condition is the commonest disease that leads to irreversible visual loss in the UK and the rest of the developed world. AMD is an acquired disease that may occur with the wear and tear of increasing age. The visual loss is gradual. There is damage to the thickness of the retina at the macula, and this causes distorted central vision. This can also be called as metamorphosia. Later on, there is progression to loss of central vision. Another function of the macula that is impaired is the diffusion of lipid debris from the retina to the choroidal vasculature. Instead, extracellular deposits form, and these can be seen as drusen or yellow spots under the ophthalmoscope. Common risk factors include older age, smoking, and Caucasian ethnicity. Age-related macular degeneration can be divided into dry and wet macular degeneration, depending on the examination findings. Dry is the commonest type, and the main findings are the drusen. Unfortunately, the progression of visual loss is irreversible. Management is focused on slowing down the progression. This involves diet improvement, exercise, and smoking cessation. Wet or exudative age-related macular degeneration is the less common form. As dry AMD progresses, neovascularization may occur at the choroid with subsequent hemorrhage into the retina due to leakage of blood. This is the reason why it is called wet. The retinal hemorrhage can then lead to acute visual loss rather than the slow, gradual, and progressive visual loss of dry AMD. Hemorrhage can be inhibited with anti-VEGF injections. However, wet AMD has a worse prognosis than dry AMD, and central vision will eventually still be lost. Moving on, glaucoma happens when there is progressive damage to the optic nerve, usually by the effects of raised ocular pressure. The intraocular pressure level is determined by imbalance between production and removal of aqueous humor. As a reminder from the previous slide in the anatomy section, the ciliary epithelium secretes aqueous humor to maintain the ocular pressure. The aqueous humor then moves along the iris to be drained at the iridocorneal angle. The angle is lined by the trabecular meshwork through which aqueous drains into Schlemm's canal, and hence into the venous system via the episcleral veins. It is important to note that optic nerve damage of glaucoma may also occur without raised ocular pressure. Risk factors for developing glaucoma include ocular pressure of more than 21, older age, family history, Afro-Caribbean ethnicity, and myopia. It is again important to note that diabetes is not a risk factor for glaucoma. Most of the optic nerve axons can be damaged before any symptoms of visual loss become apparent. This means that patients may present at a late stage when most of the axons have already been damaged. Patients will present with peripheral visual field defects due to optic nerve axon damage. These are called arcuate scotomas and can increase in size to form tunneled vision. When looking through the fundoscope, the cup-to-disc ratio will be bigger. This is because the outer rim of the optic nerve becomes thin as the nerve axons die, and this allows for the central cup to expand. Ocular pressure can be measured with the tonometer, and the thickness of the cornea, which is associated with glaucoma, can be measured with the pachymeter. There are two types of glaucoma. The classification is based on whether the iris is covering the trabecular meshwork or not. They are open-angle and closed-angle glaucoma. In open-angle glaucoma, the trabecular meshwork is not covered by the iris, and thus the aqueous fluid drainage path is opened. However, there is increased resistance in the trabecular meshwork. Aqueous fluid drainage is thus still blocked, and the increased eye pressure can damage the optic nerve. Management of open-angle glaucoma is aimed at decreasing the ocular pressure. This is the only modifiable factor, really. Treatment can be medical, or with laser, or surgical. Examples of medical treatment include those that decrease the aqueous fluid production, such as beta blockers, alpha agonists, and carbonic anhydrase inhibitors, and those that improve the outflow, such as prostaglandin analogs and the parasympathomimetic pilocarpine. Laser treatment applied at the trabecular meshwork may improve the aqueous outflow. The surgical treatment is called trabeculectomy and it involves the creation of a fistula between the anterior chamber and the subconjunctival space to improve outflow and thus lower the intraocular pressure. Closed-angle glaucoma is when the trabecular meshwork is covered by the iris. This is an emergency because the intraocular pressure can increase acutely to reach 50 and 80. This patient will complain of painful eye, headache, blurred vision, halos, and photophobia. On examination, the eye is red, hazy, and with a fixed mid-dilated pupil, which is due to the increased intraocular pressure. The management should be immediate with IV acetazolamide and then pilocarpine and beta blocker, with the aim of lowering the intraocular pressure. Pilocarpine will also constrict the pupil and lift up the iris to open the trabecular meshwork and thus allow aqueous fluid to drain. Once stable, then laser iridotomy or surgical iridectomy will permanently create a hole on the iris to prevent further attacks. It is important to note that surgical iridectomy or the laser iridotomy should be done bilaterally, even if only one eye is affected, because glaucoma can affect the fellow eye as well. Cataract is another common disease that causes visual loss. This happens with increasing age as the lens becomes harder and denser. The ability of the lens to refract is lost and light is blocked from entering the eye. The patients present with blurred vision and glare, which is worse at night. There are three types of cataract: nuclear, cortical, and posterior subcapsular. The nuclear cataracts affect the nucleus or the center of the lens. They are the most common and they are due to aging. The cortical cataracts affect only the outer layer of the lens, and the posterior subcapsular cataracts are the ones that affect the young patients who use steroids or have diabetes. Removal of the cataract is done surgically by replacing the defective lens with a new plastic one. The success rate is more than 95%. However, complications still do occur, and they include endophthalmitis and posterior capsular opacification, although the chances are really low. In the next few slides, you can see how the different types of cataract look under the ophthalmoscope. We have the nuclear cataract, the cortical cataract, and the posterior subcapsular cataract. This is the end of the visual loss section. In the next few slides, I am going to talk about systemic diseases affecting the eye. There are two important ones: diabetes and hypertension. I am only going to cover diabetic retinopathy, as this is the most likely topic to come up in your exams. Diabetic retinopathy is the most common cause of visual loss in the working population between the ages of 30 to 60. Hyperglycemia causes damage to the endothelial cells of the retina and the pericytes. Endothelial dysfunction leads to increased vascular permeability, which then causes the characteristic exudates seen on the fundoscopy. Pericyte dysfunction predisposes to the formation of microaneurysms. Neovascularization is thought to be caused by the production of growth factors in response to retinal ischemia. Diabetic retinopathy can be classified into non-proliferative and proliferative diabetic retinopathy. Non-proliferative can be further divided into mild, moderate, and severe depending on the type and number of characteristic changes. If any changes are seen on the macula, then this is called maculopathy, and this can happen at any stage of diabetic retinopathy. Maculopathy is the most common cause of severe visual loss in diabetic retinopathy. Decision on referral is based on the classification. If there is sudden loss of vision, vitreous hemorrhage, or retinal detachment, then it needs emergency review on the same day. Proliferative diabetic retinopathy needs a 2-week referral and considering treatment of pan-retinal photocoagulation. Severe non-proliferative diabetic retinopathy and maculopathy require normal referral. If there is bleeding near the macula, then anti-VEGF injections may be given, as well as consideration for focal retinal laser. Looking at the top left picture, you can see hard exudates above and below the macula. These are due to vascular damage. The top right picture shows soft exudates or cotton wool spots above the optic disc. They look fluffy and they are due to nerve damage. The bottom right picture shows what pan-retinal photocoagulation looks like. This is all you need to know about diabetic retinopathy. Now I am going to talk about the most important and relevant section of this presentation, the ophthalmic emergencies. These are retinal detachment, orbital cellulitis, temporal arteritis, endophthalmitis, trauma, corneal ulcers, chemical injury, and others. Close-angle glaucoma is another important emergency which I have covered earlier. Any vitreous detachment from the retina or traction due to proliferative diabetic retinopathy may lead to fluid getting into the subretinal space. Fluid will gradually peel off the retina from the choroid wall and cause retinal detachment. Risk factors for detachment include severe myopia, eye surgery, trauma, and family history. Patients will present with flashes and floaters. They may also describe the loss of vision as a curtain blocking their visual field. This is therefore an ophthalmic emergency, as urgent diagnosis and treatment will prevent acute, permanent visual loss. Viewing the retina under the ophthalmoscope can give the diagnosis. Management depends on whether the macula has detached or not. If the macula is still attached, then same-day surgery needs to happen, as the changes of improving the visual loss are much better. Detachment of macula means permanent loss of vision, and therefore treatment can wait for up to 1 week. It is important to note that the fellow eye may also be affected. Therefore, examination of both eyes should be done. Orbital cellulitis occurs when preseptal infection from the ethmoid sinus spreads to the orbital behind the eye. The causative organism is usually Staphylococcus aureus or Streptococcus. This is an emergency because the septal swelling can compress and damage the optic nerve, causing blindness. The infection can also spread into the brain to cause a brain abscess. The patient may present with pain, visual loss, and systemic illness. On examination, both upper and lower eyelids will be inflamed. The eye will appear red and proptosed, and there will be reduced eye movements. The optic nerve function needs to be examined and monitored regularly. These includes visual acuity, talar vision or red desaturation, relative afferent pupillary defect, pupil reflexes, and visual fields to test optic nerve function. Urgent investigation includes blood cultures, swabs, and CT to define the depth and severity of infection. Management is with an emergency referral to ophthalmology, admitting and giving IV broad-spectrum antibiotics. The left picture shows preseptal cellulitis. The swelling is more localized, involving only the eyelid. There are no systemic symptoms, and there is normal optic nerve function. You can see the same thing on the bottom left picture. The right picture shows a more diffused swelling, indicating orbital cellulitis. Optic nerve damage is also an important finding of orbital cellulitis compared to preseptal cellulitis. Temporal arteritis is an autoimmune vasculitic inflammation of the temporal artery. This is a branch of the external carotid artery found on the scalp. Temporal arteritis is also called arteritic ischemic optic neuropathy due to its resulting ischemia of the optic nerve. Both eyes can be affected. Loss of vision in one eye is irreversible, and immediate management is necessary to prevent loss of vision of the fellow eye. Patient is typically above 60 years of age. They present with acute loss of vision, scalp tenderness, and pain on chewing, otherwise called jaw claudication. Temporal arteritis is often associated with polymyalgia rheumatica. These patients will also present with stiff shoulders, weight loss, and malaise. On examination, the optic disc will appear swollen. Early recognition is essential for immediate management. This includes immediate IV steroids, blood tests for ESR and CRP, and temporal artery biopsy. This is a very rare emergency due to bacterial infection following cataract surgery or this endophthalmitis is a very rare emergency due to bacterial infection following cataract surgery or penetrating trauma to the eye. The patient will present with severe and rapidly escalating painful visual loss. On examination, hypopyon may be seen in the cornea and a red eye. The posterior segment will be hazy as the vitreous becomes opacified due to white blood cells and other inflammatory products. The management is with immediate ophthalmological review, cultures taken from biopsies of aqueous and vitreous fluids, and injection of intravitreal antibiotics into the eye. Moving on, penetrating injury to the eye can occur with sharp or tiny objects. The patient will present with gritty eyes, pain, and variable loss of vision. On examination, there will be irregularly shaped pupil. This requires immediate management with referral to ophthalmology, CT of the orbits to locate the penetrating objects, oral antibiotics, and tetanus prophylaxis. An implant object being thrown to the eye can cause hemorrhage behind the eye. And this is called retrobulbar hemorrhage. This is an emergency as it can cause rapid permanent blindness. The patient will present with pain, blurred vision, and inability to open or close the eyes, as well as diplopia. On examination, there will be subconjunctival hemorrhage, proptosis of the eye, restricted eye movements, and reduced optic nerve function. Management is with immediate referral to ophthalmology for orbit decompression to avoid any optic nerve further damage. Chemical injury occurs when toxic solutions come in contact with the eye. The most severe injury is with alkaline solutions. Treatment is with immediate irrigation with water to lower the pH. Corneal ulcer is an infected lesion on the cornea. It is also called microbial keratitis. The common causative organism that you need to be aware of is herpes simplex. Infection with this virus creates a characteristic dendritic shape when stayed with fluorescein. Risk factors include poor hand hygiene and sleeping or swimming with contact lens for people who wear them, or trauma. The patient will present with painful, gritty eyes, photophobia, discharge, and blurred vision. On examination, there will be white opacities seen in the cornea when stained with fluorescein. The management is by obtaining corneal scrape for cultures and giving broad-spectrum antibiotic drops. Those are the ophthalmic emergencies that you need to know. To close off the presentation, I am going to talk for a few last minutes about pediatric ophthalmology. The conditions I am going to talk about are retinopathy of prematurity, squint, and amblyopia. Retinopathy of prematurity is the incomplete retinal vascularization followed by aggressive neovascularization. There is an increased risk for low birth weight and premature infants. Supplemental oxygen therapy is also a risk factor. Neovascularization and fibrous tissue formation may lead to retinal detachment and bilateral blindness. This is why all premature infants should be screened for retinopathy of prematurity. Squint and amblyopia are common findings in the pediatric department. Squint is when one eye is directed towards a fixated target while the fellow eye cannot fixate. It can be either exotropic or esotropic. Exotropic is when the affected eye takes a more temporal position. In contrast, when the affected eye takes a nasal position, it is called esotropic. Squint during the first 5 years of age may lead to failure of visual maturation of the affected eye. These will lead to amblyopia or lazy eye and thus permanent blindness. Amblyopia can be prevented by patching the non-affected eye during this critical stage of visual development and forcing the squinting eye to focus on fixated objects. We have reached the end of this presentation. There are only a few things we haven't covered, which I have listed here along with some important points for each. Good luck with your exams. Thank you.